the little clip that shows what we see when we do the eye tracking. And what you see is that the eye tracker records the eye movement, and the longer that a person looks at a place, the dot gets bigger. And so we can not only look at the order in which people look at a picture, but also how long their gaze is in specific parts of the picture. Now here is a sort of outtake from this. And here you see that the scan path is numbered, so you know the order. And then the bigger the dot is, the longer the person is looking. And this is another way of visualizing, with the red in the center being longer gaze duration. And what normally when people look at faces, they look at the eyes, then at the mouth, so there's this kind of triangulation. This technique was initially used in autism research to show that children with autism don't look very long at the eyes, and then their gaze just kind of drifts off, so they don't show that regular triangle. Now, we showed faces of different emotions to kids, and what we found is that the preschoolers with anxiety spent a significantly longer time looking at just the eyes of these different faces. But then we wanted to look beyond just faces and look at more complex pictures with different emotional valences, so positive and negative, and social and non-social. So we use these pictures, which are called IF. So here's an example of a neutral social scene, and you wouldn't expect there to be a difference between anxious and non-anxious children, and in fact, we don't see any difference. In these slides here, blue will always be the non-anxious kids, and the red will be the anxious kids. And that just shows what the hot spots look at. So they're looking very actively at the picture, but there isn't difference. But here is a picture in which there is potential threat, which is a dentist drilling on this boy. And what we see is quite intriguing. So there was no difference in the two groups in looking at the drill. They both looked at that drill. But where there was difference was that the children with anxiety disorders spent a longer time looking at both the face of the child, is he okay, but also at the face of the dentist. Is this person trying to hurt this person? Is this child safe? Now, this is not confined just to a social threat. We also see the same thing, that in looking at this picture of this scary dog, that the anxious children spent a longer time looking at the eye and at the teeth. But here, this picture here of the roller coaster gets us to that ambiguity question that I was addressing before, and interpreting social situations. So the kids showed no difference in how long they looked at the dad. But the kids with anxiety disorders spent a significantly longer time looking at the children's faces. And my interpretation, again, is very early, is, are they scared or are they having a good time? And really trying to understand the meaning, the social meaning, and potential threat in this picture. But again, thinking about that story about looking at happy faces, the anxious children spent a longer time looking at these cheerful, happy girls with their faces overall and their eyes. So this is suggesting to us a story about anxiety disorders having to do with interpretation of social situations, processing of social situations, not just fear and threat. And this is the last picture just to show that positive non-social pictures, that's a picture of a bag of M&Ms, there was no difference between the two groups. So this really has to do with something in terms of social situations and then threat. So in summary, these data suggest a number of things. One, that anxiety disorders overall and separation, GAD, and social phobia are common in preschool children. We also have shown that these disorders have similar comorbidity. They show distinct patterns of continuity after the preschool period. And the point that I made earlier that I haven't shown too much data about, but that GAD may have to do more with early onset depression than anxiety. And anxiety disorders in preschoolers is in many ways similar to that in older kids. The diagnostic presentation is similar. The rates are similar. The rates of comorbidity are similar. The children are very impaired. These disorders predict later psychiatric disorder. And lastly, some of these early data are suggesting that the neural substrates may be similar. Now that's the piece of my talk that focuses on my program of research and the epidemiology and the neuroscience of early onset anxiety disorders. But I wanted to be sure to address some of the nuts and bolts information about assessment of young children and treatment of children with anxiety disorders. So here I'm just going to provide somewhat of a brief overview of issues related to being in a clinical setting. Now, these are key aspects of the assessment of young children that are not specific to anxiety disorders. These apply across all domains. And the critical thing to understand in assessing very young children is it cannot be done in one 45-minute or hour session. It is not possible to do that. And so you're going to need to have multiple sessions. You're going to have multiple informants. An assessment is going to have to be multidisciplinary. It cannot just be done by either a pediatrician or a child psychiatrist. You have to use multiple modes of assessment. And lastly, you cannot make a single diagnosis. You must do a comprehensive multi-axial assessment to really understand what's going on. So here are some details in terms of doing multiple sessions. The main point is you must see the child with the parent. If you can, see the child alone. But often it's extremely important, at least this is what I do in my clinical setting, to see the parents without the child, because there are things that you may need to talk about, that you will need to talk about with the parents, that shouldn't be talked about in front of the child. Parents' psychiatric history, substance abuse history, marital problems, domestic abuse. These are key factors that have to be addressed, but should not be talked about with a 2-year-old sitting on the floor next to you. Now, it's also critical, as I said, to have multiple informants, and that, of course, will include parents. But one needs to remember you want to include parent figures. Families come in all different kind of constellations. So there may be a grandmother who cares for the child during the day, a nanny, or other kind of caregiver who will have vital information about that child and about that child's experience. Another point, and people can think I'm silly to say this, but unfortunately I've had clinical experience where it's true, you must meet with the child. I mean, one of my early supervision cases with a resident was telling me about a case, and I asked about the child, and the resident said, oh, well, she was in the stroller in the room. I said, the child didn't get out of the stroller? You didn't assess the child out of the stroller? And the resident was like, no. And this was a child, unfortunately, who had come on a number of psychiatric medicines. And so I always use that as the example, this stroller child. You must not only have the kid, out of the stroller, but do an assessment and find out what that child's experience is. You must talk to the teacher or daycare provider, and then it's very critical to talk to other clinicians and caregivers. And with young children, that may be pediatricians, developmental psychologists, but also occupational therapists or other kinds of early intervention clinicians. This is just stressing the point that I just made, is that the assessment is multidisciplinary. So it's not just obtaining information, it's also collaborating. And one of the roles that I think a child psychiatrist has the opportunity to play in infant and preschool mental health is to take the lead as the person who is going to integrate all of this information together to come up with a comprehensive assessment and treatment plan. Often parents are asked to go from office to office to office, and various assessments are done, but nobody takes the responsibility to pull that together. And that's critical, and I do think it's a role that child psychiatrists or perhaps child psychologists can fill. Now, this is to say you also have to do multiple types of assessments, and that is using different checklist measures or structured interviews, other developmentally appropriate assessments with the child, either structured or semi-structured play at the child to get at that child's experience, using observational assessments either in your own office